Good morning. We'll see in this video the diagnosis, etiologies, and treatment of hypoglycemia. We'll start with the definition. Whenever we say hypoglycemia, we say Whipple triad. It contains symptoms or clinical signs of hypoglycemia, blood glucose level below zero point 0.7 gram per liter, in patient with diabetes, or in patient without diabetes mellitus, it is below 0.5 gram per liter to confirm hypoglycemia. And of course, when we give the patient, when we restore the normal blood glucose level, there is resolution of symptoms. Hypoglycemia is a diagnostic and therapeutic emergency. So for the clinical signs, we have mild hypoglycemia, we have moderate hypoglycemia and severe hypoglycemia. We start with the mild hypoglycemia. The blood glucose level is between 0.54 and zero point 0.7 gram per liter. We have adrenergic signs, contains cold sweats, tremors, palpitation, and sometimes painful hunger. We can have also fatigue, headaches, pallor, sometimes nervousness, and difficulty on concentration. If we don't treat the patient when he has mild hypoglycemia, we might have moderate or severe forms. So for the moderate hypoglycemia, the patient can self-administer sugar. So he can treat himself with sugar. But in the case of severe hypoglycemia, it requires third-party assistance. So we have adrenergic signs, but also we have neuroglycopenic signs with blood glucose level below 0.5 gram per liter generally. For the signs of neuroglycopenia, we have sometimes speech disturbance. We might have also behavioral disorder, blurred vision, confusion. The patient might have seizure sometimes, but it is severe to have agitated coma. So there is multiple factors. When the patient have adrenergic signs, then he has neuroglycopenic signs. Sometimes it is related to sugar unavailability in case of sleep, handicap, failure to recognize adrenergic signs. So the patient know that he is aware of the symptom. For example, he have tremors, but he don't know that tremors is a sign of hypoglycemia. So there is a lack of education of the patient. With beta blockers and in case of autonomic neuropathy, the patient don't cannot recognize the signs because it is masked. So it is the same in case of repetitive hypoglycemia. So the threshold is below the normal. So when it is zero point 0.7, normally the patient might have zero point 0.3. So when he has hypoglycemia, his blood glucose level is zero point 0.4. He doesn't have adrenergic signs, so he might have seizure without adrenergic signs. For the complication, the patient with hypoglycemia risk to have cardiovascular accident, so myocardial infarction, stroke, sometimes sudden death. The patient could have fractures secondary to falls, road traffic accident. In case of repetitive hypoglycemia, the patient could have encephalopathy with cognitive decline or academic delay in children. For the etiologies, there is multiple etiologies. We'll start with those related to diet or activity. So for the physical activity, if it is unusual, long in duration, so the patient without taking snacks, for example, and without adjusting the dose of insulin or sulfonylurea, the patient would have hypoglycemia. For the diet, the patient might not eat his meal, or he might do the injection of insulin and delay the meal. In this case, he might have hypoglycemia. Sometimes it's required for the patient to take snacks, but he forgot to take it, so He could have also hypoglycemia in case of Ramadan fasting, or if he eats without carbs. So the patient also could have hypoglycemia if he take rapid acting insulin, for example, and the food doesn't contain enough carbs. So in this case, hypoglycemia is frequent. Sometimes the etiology is related to insulin, so the patient do the injection of insulin directly to the muscle. So intramuscular injection could cause hypoglycemia. If you do the injection in the same zone, he could have lipodystrophy. In this case, the patient could have hyperglycemia, and at the same time, he could have both hyperglycemia and hypoglycemia. For the overlapping doses, so for it is generally for the patient taking NPH, so it is intermediate acting insulin. In this case, the patient is required to do it twice a day, for example, at 8 a.m. and 8 p.m. If the patient do the injection at 11 a.m. and at 8 p.m., he will have 3 hours of overlapping doses between 8 p.m. and 11 p.m. So 3 hours of overlapping dose, and the risk of hypoglycemia is important. Sometimes the patient do the injection correctly, but he took more than usual dose because he has cataract or retinopathy. So in this case, he, he might have excessive dose. For the etiology related to associated organic condition, the patient could have liver failure. Sometimes the patient with, especially the patient with autoimmune disease, could have adrenal, like type 1 diabetes mellitus, could have adrenal insufficiency or celiac disease, and these are frequent cause of hypoglycemia, especially in patient with type 1 diabetes mellitus. For the diabetes complication, there is diabetic neuropathy or autonomic neuropathy. So the patient with gastroparesis, for example, will have hypoglycemia in just maybe 1-2 hours after the meals, and later when the food will pass to the intestine. In this case, he will have hyperglycemia a little bit tardive. For the other causes, it is related to sulfonylurea. So the patient might have dementia. In this case, he will take multiple doses, or there is a drug interaction between sulfonylurea, anticoagulant, for example, or sulfonamide. In this case, there is severe hypoglycemia generally, and it can happen again in 72 hours. So generally, the patient is hospitalized. Other causes are alcohol and consumption and factitious intake of insulin or hypoglycemic agent. So for the treatment, the patient could be conscious. In this case, we'll give him between 15 to 20 grams of sugar, orally, of course, and the correction of the underlying cause, if possible, it is always the case. So, in case the patient don't have sugar, he could take 200 milliliter of juice, of soda. He could take also jam, honey, or ampoules of glucose, 30% glucose. Every ampoule have 3 grams of glucose. For the patient who is unconscious, in this case, we should give him between 2 and 3 ampoules of 30% of glucose directly intravenous administration. Then it is followed by 10% of glucose infusion until awakening. This is available for patients with type 1 and type 2 diabetes mellitus. For patients with type 1 diabetes mellitus, we can give the patient also, or alternatively, 1 milligram of glucagon, whether it is subcutaneous or intramuscular. We can give him this option or the first option. Both are available for patients with type 1 diabetes mellitus. For patients with type 2 diabetes mellitus, especially those who are taking sulfonylurea, it should be contraindicated to give them glucagon because it stimulates beta cells, so there is secretion of insulin later, so the patient could have hypoglycemia again. For the prevention, we should educate the patient about adjusting the treatment. He should adapt the treatment with the food intake. and at the same time with the physical activity. For example, those patients who have planned physical activity should take carbohydrate snacks. The patient should take food with carbs and avoid Ramadan fasting without consulting his doctor. The patient should also use blood glucose monitor. He should check his glycemia before driving, at bedtime. The patient should know adrenergic signs and the appropriate action. For example, if the patient has tremor, he should know that tremors might be related to hypoglycemia, and he should check his blood glucose level. We should also educate the patient on the insulin injection techniques. For the entourage, we should educate them about neuroglycopenic signs. So when the patient presents signs of neuroglycopenia, we should give him sugar and of course verify his blood glucose level. For those who have a child with type 1 diabetes mellitus, we should educate the parent about glucagon injection techniques.